Thank you, Mr. Chairman. Ladies and gentlemen, I'd like to thank the organizing committee for the opportunity to be with you today to talk to you about the complexities of cirrhosis. These are my disclosures from the research that we do at Duke. So I want to set the stage a little bit. Cirrhosis is a leading cause of death in the world. Overall, it's the 12th leading cause in these statistics from 2010, with about 1 million deaths worldwide. I've learned at this meeting that it's even an increased risk in Indonesia. For us in the United States, it remains similarly the 12th leading cause of death, and over 30,000 people a year die from cirrhosis. And the hope is that if we can understand the complexities around cirrhosis, perhaps we could reduce the deaths. But there are a number of factors that we would have to consider when you are trying to impact a rather complex disease that plays out over decades. So can we prevent the chronic injury that leads to the cirrhosis? Can we identify the patients with cirrhosis? In the U.S., I can tell you that we often find that patients show up way too late in the course of their disease. Once we do find cirrhosis, how well can we prevent and manage those complications? And there's been a lot of research trying to look at therapies that would be antifibrotics. And if we could do that, could we reverse the trend? So these are the causes of cirrhosis in my clinic. And I realized that if I was practicing in Jakarta, it would be a lot more hepatitis B. But for me right now, hepatitis C remains the most common thing that I see. However, thanks to all the new hepatitis C drugs, we are already seeing that my clinic is starting to look more like this. And for us in the United States, fatty liver disease is fast becoming the most common reason someone comes to see a hepatologist. But regardless of the causes of cirrhosis, there's some similar things that we see. So patients, that doesn't show. You start with chronic injury, some degree of inflammation, whether it's from a virus or alcohol or NASH. And then in response to that inflammation, the healing process leads to matrix deposition and fibrosis. And if it's caught early on in fibrosis, one can impact that and even have resolution of it. But for some people, not all patients, but some patients will go on and develop cirrhosis. And that may be related to a number of factors. Some patients are probably genetically at risk to develop cirrhosis, and others may have cofactors that are playing a role. We know that whatever your underlying liver disease, if you drink alcohol heavily, things will progress faster and are more likely to progress. So we do see these patients that, again, over the course of decades, will go on to develop cirrhosis. But even at that point, we have learned that we still might be able to impact the course of the disease. And so we look at a number of factors, whether it's controlling the inflammation, what have you, with the hope that we can either slow it down or even turn things back around. But the reality is that some patients will still be at risk for developing hepatocellular carcinoma, and other patients will also develop liver failure and portal hypertension and need a liver transplant. So I often think about where my patients are along the spectrum of portal hypertension, and that helps me categorize them a lot. So once I meet someone who I think has developed cirrhosis, often we don't do a lot of hepatic venous portal gradient measurement, but when we do, we think about it in this way. A lot of patients will start to have some degree of elevation and get into the 6 to 10 range, but still be at the compensated cirrhosis level. When they progress onto decompensated cirrhosis, it usually the gradient is above 10 millimeters of mercury at that point. We know that once they go above 12 is when they start to develop varices. But then there are these patients that has gone even further. They're in the 16 to 20 range, and that we call late decompensation. And we've been trying to better characterize patients as we think about where they are along the spectrum. So these are the stages of cirrhosis that our guidelines now use. So if someone has compensated cirrhosis, you might still see some mild features of portal hypertension. But then at some point they move on to what we would call clinically significant portal hypertension. They may not have varices, or they may even have small varices. When they move on to decompensated cirrhosis, then something has happened. They may have had variceal hemorrhage, they may have developed ascites, or they may have had hepatic encephalopathy. At this stage, for many patients, we can still manage things quite well and get them back to a reasonable quality of life. Then there are the patients who develop late decompensation. They are struggling with recurrent variceal hemorrhage. The ascites is difficult to control. They have hyponatremia, or their sodium level is quite low. They may develop hepatorenal syndrome, and things have become quite serious. They may have recurrent hepatic encephalopathy and severe jaundice. That distinction about when people go from compensated to decompensated cirrhosis is extremely important. I really try to make sure that a patient and their family understands when that change has happened, because it does impact their survival. When I meet a patient who has compensated cirrhosis, I know that there's a good chance they could stay that way for quite a while. In this one analysis, the median survival in compensated cirrhosis was 12 years. But when you went to decompensated cirrhosis, it's down to 2 years. They're at greater risk. On the right is an analysis from the UK, looking at the patients in blue with 1 year survival, and the brown, or color I guess it is a 5 year survival. And you see what is a compensated cirrhosis, the 1 year survival is 87% and 5 years 67%. But when we come down to the decompensated cirrhosis, the 1 year survival is 75%, and the 5 year survival is now 45%. These are our patients at great risk of dying. So what can we do? So we know that the most powerful thing we can do right now is to prevent the chronic injury. We're learning about this with hepatitis C. We talked a little bit about this morning. Hepatitis B is probably one of the best examples we have that effective antiviral therapy can stop for the progression and improve things dramatically. We see the same thing with autoimmune hepatitis. Effective immunosuppression stops that and can make the liver disease regress. Unfortunately, we don't have therapies for all our liver diseases. There's nothing available right now for me for NASH, PSC, or alpha-1 antitrypsin deficiency. But just to highlight what we can, again, hepatitis B is really where we first saw this. This is a figure from this paper. It shows a 51-year-old man who had chronic hepatitis B. And the top panels are his liver biopsy before he was treated. And you see that he has F4 fibrosis at that point. He was treated with lamivudine, and after 8 years, the bottom pictures are his biopsy at that point, and now he's at F1. And this went against everything that I was taught in medical school, but it was important to see and to know that even at that late stage, we can change things. This has been important for us, and we, in the United States, we hardly ever transplant for hepatitis B anymore, thanks to these effective therapies. It's been really wonderful. So how about hepatitis C? I think we are learning that hepatitis B and hepatitis C are different this way, but we're still early in our understanding of it. So this is the Astral-4 study, which treated patients who had all the genotypes, but all these patients were Child-Pugh class B. So they had decompensated cirrhosis, Child-Pugh B. Their platelet count had to be at least 30,000, and they had to have good renal function in this study. And it was a randomized control trial that looked at giving patients sofosbuvir and velpatasvir for 12 weeks, or that regimen with ribavirin for 12 weeks, or that same regimen for 24 weeks. What you see is that the best result came with giving the sofosbuvir velpatasvir with ribavirin for 12 weeks. But you see that all the regimens actually were quite effective. And we have become spoiled in hepatitis C and expect to see 99 and 100% all the time now. But in a patient who had Child-Pugh B cirrhosis, up until these drugs, we did not have anything to offer such a patient. So cure rates here are important. But what we don't know is how those patients will do. If you already had Child-Pugh B cirrhosis and you were dealing with ascites and you were having trouble with variceal hemorrhage, will curing the hepatitis C fix that? Or will you still have ascites and encephalopathy and those problems? Most of the data we have at this point are anywhere from 12 to 24 weeks out from treatment. And I think it will take several years for us to understand this better. and we'll need that to be able to guide patients around this. We know that cure of hepatitis C can be important. This study looked at patients who had compensated cirrhosis, so not yet at decompensated. This was in the interferon era. And we know that when we cured patients of hepatitis C back then, before they went decompensated, we know it improved their results as far as progressing on to need a liver transplant, lower rates of liver cancer, and lower overall mortality. So all results were improved. We need to understand what's going to happen in the DAA era in this way as well. We also know, though, that things don't go away. I always like to point this slide out to my fellows and to my patients, actually. This is a study, again, of patients who, from the interferon era, who had compensated cirrhosis, Child-Pugh Class A. They were cured of their hepatitis C. But what you see is that a small number of those patients still had complications of cirrhosis. Some had developed HCC, some developed ascites, and one developed hepatic encephalopathy. I would notice that 3 of the cases of HCC occurred more than 7 years after the patients had been cured of their hepatitis C. So the risk has been decreased, but it has not been removed. It has not been eliminated. So these patients need to be continued to be monitored. What we need to figure out, though, and what would be helpful is to determine, is there a time or some kind of marker that we know that your liver is too sick and you need a transplant versus your liver at this point, if we can cure you, we could turn things back and you can avoid a transplant. That would be very important for us to do. But we actually don't have enough information and data to understand that. We are trying to generate that data. There are a number of registries going on in the United States and in Europe looking at all these patients who had advanced liver disease and have been cured, and we await those data. So stay tuned. But what can we do well before decompensation occurs? I feel like when I meet a patient now who shows up in the hospital with a new diagnosis of cirrhosis from variceal hemorrhage or ascites, we missed a chance. So we find in the United States that we do a poor job of identifying patients with liver disease. These data show that in the U.S., even in hepatitis C, which is our most common, most patients are not aware they have hepatitis C, and because it's a quiet disease and they haven't been found. We think there are similar concerns with fatty liver disease. We do not know how many of our patients have it. They generally don't show up to care until they're quite advanced, and so we are trying to come up with better ways to screen. There is some suggestion that there's more than 1 million Americans with fatty liver disease that's at risk for cirrhosis. And we are starting to see more transplants for this condition. If that plays out, then we have great concern. So again, we have to try to identify them more. We're trying to do more screening. And we also need to make sure we accurately stage patients. I often see somebody who was found to have abnormal liver tests more than 10 years ago, and when I look back, it was pretty obvious to me that they had cirrhosis, but their general practitioner or family doctor, it was not clear to them. So we try to talk to them to make sure that these signs and symptoms of cirrhosis are noted. They can be subtle, but if a patient develops anorexia, weight loss, weakness, muscle wasting, we need to consider that. Those can be from other causes, but cirrhosis is part of it. It's more obvious if they have jaundice, edema, ascites, bleeding, and mental status changes. We look for the physical examination signs. Do they have spider angioma, palmar erythema, gynecomastia, capimedusa, ascites, and again, lower extremity edema, but splenomegaly or muscle wasting. These are all things that I see in my patients. I find that we probably overorder labs in the United States, but I often see these people have had a low platelet count for several years, and nobody noticed that. Nobody called that to our attention or thought it may have been from some other cause. It's more obvious when their bilirubin is elevated, their PT-INR is out, and the albumin is low. My professors always taught me to look at the AST to ALT ratio, and it should be 0.8. But if it's more than 1, that suggests cirrhosis, unless the patient is consuming alcohol. We used to use liver biopsy very aggressively. We do so less now. We've gotten away from it a little bit because patients don't want it as much, despite the fact that it has overall good outcomes. But there's also a sampling issue to it. You're taking a very small piece of the liver and trying to comment on a large organ. I noticed there was a poster today about transjugular liver biopsy, and we do use that if the patient is not a candidate for percutaneous liver biopsy. Maybe they have ascites, or maybe they have a coagulopathy. But we have a number of studies looking at trying to impact portal hypertension, and that's probably a common place that I use it when I'm trying to understand the degree of portal hypertension, and this provides both a way to measure that gradient and to get a piece of the patient's liver if needed. There's been much more activity in the United States over the last decade around alternatives to liver biopsy, whether the use of the serum panels or the radiographic tests. And we do have a FibroScan in my clinic. I know you all have one here in Jakarta. I do find that's been a very important tool for us. I would just caution about a couple of things with all of these non-invasive markers. Although they will provide a score that can tell you stage 1 versus stage 2 versus stage 3 versus stage 4, the test characteristics around that are not good. These tests are best when they are used to say, do you have cirrhosis or not? So cirrhosis, yes or no. Otherwise, the test characteristics break down quite a bit. This is the vibration-controlled transient elastography, or FibroScan, that's commonly used. It's an ultrasound-based technology. It sends a shear wave into the liver, and then the speed of the shear wave is measured. And you get a range and score of kilopascals there. I was involved recently in an analysis looking at these data. I can tell you the data are varied. Different thresholds were used, but these are the generally accepted ones for hepatitis C. So normal is less than 5 to 6. Advanced fibrosis is 9.5. Cirrhosis is more than 12.5. And if it's more than 17, then they likely have portal hypertension. Our guidelines now say that if the transient elastography score is less than 20 and the platelets are normal, you don't need to do an upper endoscopy for varices. This is magnetic resonance elastography, which has some advantages in that it is looking at the entire liver, whereas the FibroScan, for example, is just looking at a small chamber. On the left here is a normal patient. On the right here in red is a patient who has more fibrosis. I will tell you that this has mainly been used for research purposes in the United States. It's not widely available. I'm not sure how widely available it will be because it will be expensive, but it is a helpful way to characterize patients' liver disease. And our American society has recommended it, particularly in fatty liver disease, because some of our other modalities do not work as well when the patients are obese. We'd also like to see if we can measure liver function. This is a breath test that was recently presented at our Liver Society meeting, and it's basically trying to look at metabolic liver function. But also, what I found very interesting about this analysis was when they looked at it, they looked at patients who are healthy versus patients who had fibrosis versus patients who were child A and patients who were child B or C. And what they found was that this might be a way to replace the invasive measurements of the hepatic venous pressure gradient. It would be nice if we had another test to do that. This needs further study before we can use it, but I would watch out for this because I hope it will be effective. So how do we guide patients? The Child-Pugh score is what we commonly use. I know you all know it. I do talk to patients still about this. These are the common data that are represented, particularly when they get down to Child-Pugh C. We know that their 1-year survival is down to 45%. Their 2-year survival is down to 35%. And I often use this in discussions with our surgeons around the risk for my patients with liver disease having surgery. In the United States now, the MELD sodium score is what is used for allocation of liver transplantation. It takes the MELD score, which uses bilirubin, creatinine, and PT-INR, and most recently we've added in the sodium levels as well. This was first developed to predict post-TIPS mortality, but now is used for liver transplant allocation. And this shows you just some common MELD sodium scores. The first column here shows a patient who has a normal bilirubin, PT-INR, creatinine, and sodium. And you see the MELD sodium score is 6, and the 90-day mortality is less than 2%. As you move across the table and the numbers get higher, and the MELD sodium score ultimately goes to 35, and you see the 90-day mortality is now 65 to 66%. And we've used this, therefore, in a number of ways to guide patients. So the way we use this is if the MELD sodium score is more than 15, that is the point at which we would have a discussion with a patient around whether or not they may want to consider a transplant and whether or not they might be eligible. Even if there are some patients in which the MELD sodium score is still not great, but if they've had a complication of cirrhosis, if they've had a varicose hemorrhage, they've developed bacterial peritonitis, at that point we would also refer them for evaluation. So let's say they have started to develop these complications. We're very aggressive once we see them about trying to either avoid the complications or manage them well. So varices, we aggressively do endoscopy to look to see if the presence of varices are there. We'll either use beta blockers or banding, depending upon the patient. If they do have a varicose hemorrhage, they get antibiotics. We do not have terliprest in the United States, but we do use octreotide, and then we use endoscopy aggressively. This group knows well about the importance of the management of ascites through sodium restriction and diuretics. We also use paracentesis as needed. We also use antibiotics for prophylaxis if either the patient has a history of SBP or if they're at risk. We use lactulose and rifaximin for encephalopathy, and we use ultrasound generally for hepatocellular carcinoma surveillance. We become more aware of acute-on-chronic liver failure as a problem. Patients known with chronic liver disease that have some kind of acute decompensation that makes things progress. This has been the topic of a lot of recent work in our field. This study looks at the triggers in 2 cohorts and shows you that it varies a little bit depending upon where you are in the world. The first one there is from Europe. The second one is from China. You see in China, there was hepatitis B exacerbation was a common cause. Infection is something that we worry about very much in all cohorts. And in the European one, alcoholism was there. But we have to be mindful and think about all these things as we move forward. All of the organ systems are at risk. And once we start to lose one organ system, things progress quickly. The European group actually has developed a score. It's not been validated at this point, but if you're interested, I do think that's something worth looking at. And it can be a way to guide potentially patients, and I think is something that we'll see more of with time. I also think this issue around guiding patients about their risk of surgery is important. Often patients, even with compensated cirrhosis or maybe early child PUB, may feel very confident about surgeries, and they need to understand that there are risks. In the U.S., we've tried to be more aggressive about nutrition. This, up until I would say the last few years, was not a strength of ours. We particularly talked to them about the need for more protein. We try to be very aggressive about that with their diet. We also try to look at their vitamins and minerals and make sure that we are supplementing them appropriately. Our patients often feel unwell, they have poor appetite, and we try to be aggressive there. We've also seen that patients with cirrhosis get admitted to the hospital, and they are one of the groups that's very likely to get readmitted. They can go in and out of the hospital quite a lot. And so there's a lot of discussion about how we might try to understand how to reduce that risk, because we know that in this group you see that 69% of the patients were readmitted, 37% within a month, and 14% within a week. So we do things now like try to see them very soon after discharge, call them in the days to make sure that they're clear about their medicines, whatever we can do to help them be successful. I'm going to close talking a little bit about therapeutic options, and I will tell you we don't have an obvious cause, but it remains a great area of interest, and the hope is that we can figure out the right way to approach this. Here I show you some of the potential targets in the development of fibrosis. We know that we have inflammation, and in response to inflammation, we ultimately get cell activation. As you notice, there are a number of potential targets here, and the issue will be identifying either which one or which combination might be appropriate. I had the recent fortune to work on this one program that looked at LOXL2 inhibition. LOXL2 was thought to be a good target because it is involved in fibrogenesis and collagen cross-linkage. And simtuzumab was developed, which is a humanized IgG4 monoclonal antibody against LOXL2. We had large studies that looked at patients with NASH and PSC. The patients were treated for 2 years. They had 3 liver biopsies. And in the animal models, I can tell you it looked very promising, and the studies were negative. And I learned a lot about this, and I do think it will be challenging to understand this, but it's important that we keep trying. So in conclusion, cirrhosis remains a leading cause of death worldwide. I think there are a number of strategies that we could take in this complex disease that could alter that. Key is early identification of patients. Too many patients have no idea that they have advanced liver disease until they show up at a life-threatening stage. Once we identify that, we need to aggressively try to treat whatever is driving that inflammation. Once we identify the patients, we need to aggressively manage the complications, try to avoid them or limit their impact. The nutrition of our patients is also critical. And as we proceed, we need to determine what antifibrotic pathways are the right ones and how we can identify therapeutic targets and study them in clinical trials. And again, thank you very much for the invitation to be here today.